Hello, Assalamu alaikum. I hope everyone is fine. So let's recapitulate a headache for GPs and other specialties rather than neurologist or psychiatrist. So headache. Let's start with classification of headache. There are two types of headache: primary and secondary. In primary, there is migraine, tension type headache. Trigeminal autonomic cephalgias, that is cluster headache and trigeminal neuralgia. And in secondary headache, uh, the things that must be excluded are subarachnoid hemorrhage, meningitis, and SOL, space occupying lesion. So let's evaluate headache step by step according to onset, sudden onset. The first thing to be excluded in sudden onset headache is subarachnoid hemorrhage because it is the worst ever headache, often occipital, and there may be stiff neck and there may be loss of consciousness. Reversible cerebral vasoconstriction syndrome, it's a rare condition. There may be often recurrent thunderclap headache mimicking subarachnoid hemorrhage. Reversible cerebral vasoconstriction syndrome, rare condition, recurrent thunderclap headache mimicking subarachnoid hemorrhage. There may be some triggers involved like physical exercise, sex, swimming, Valsalva maneuver. Sometimes some people develop this sort of headache while taking off airplane. Usually benign, but beware of stroke risk. Meningitis, we all know there may be fever, photophobia, neck stiffness, purpuric rash, coma. We should do an LP, provided that there is no raised ICP, and start antibiotic empirically. Do not wait for culture and sensitivity report. Encephalitis, fever, odd behavior because it's a global infection of brain. Fits, loss of consciousness. Do an urgent MRI and LP. Intracranial hypertension. In intracranial hypertension, there will be CSF leakage, often that is iatrogenic following a lumbar puncture or epidural anesthesia, or spontaneously following minor trauma. Suspect this when headache is worse on standing. Treat with epidural blood patch. After overlook after conservative management with IV fluid or caffeine has failed. In surgical wards, this intracranial hypertension or CSF leakage is common. This is known as post-dural puncture headache. And we usually treat it with IV fluids and caffeine, and if it fails, then epidural blood patch. So this is also called post-dural puncture headache, common in surgical wards. Cervical artery dissection. This is also a rare condition. This will be ipsilateral to the cervical artery dissection, often progressive, but can be rapid onset. Look for Horner's syndrome because in the course of cervical artery, the stellate ganglion is related. In Horner's syndrome, there is ptosis, meiosis, anhidrosis, and anophthalmos. We should look for these signs. Pulsatile tinnitus. Pulsatile tinnitus. I remember a case from my clinical career that a person suffering from tinnitus for a long time. He did everything he could to get rid of this tinnitus. Did impedance audiometry, PTA, MRI of brain, and even he took cognitive behavioral therapy to get rid of tinnitus, but the ringing kept on. It was so distressing for him. So ultimately, I did a carotid duplex, and it came out to be a cervical artery dissection. And a carotid endarterectomy was done following it. Anterior or posterior. There may be precipitating causes for headache, like head trauma, can produce localized or generalized headache. This apple freeform hangs a bit. If it lasts more than 2 weeks, and if headache lasts more than 2 weeks, and that is refractory to analgesia, we should do a CT to exclude subdural or epidural hematoma, especially in elderly, because in elderly people or alcoholics, minor trauma can lead to subdural hematoma. We should also look for lucid interval or any focal neurological signs, query on sex or any food like chocolate, cheese, coffee, etc. because these trigger migraine. These trigger migraine. Okay, now let's come to the duration. A chronic progressive headache can indicate raised ICP. If the headache is chronic and progressive, it indicates to raised ICP, typically worse on morning, lying or bending forward, and during coughing. There may be associated vomiting, papilloedema, and there may be false localizing signs or odd behavior. We are not going to false localizing signs because we are not lecturing on basic neurological examination. So, an MRI should be done to exclude a space occupying lesion. And so also, we should consider idiopathic intracranial hypertension in this case. LP is contraindicated in acute raised ICP due to risk of cerebellar herniation. This is very important. A lumbar puncture is contraindicated in acute raised ICP due to risk of cerebellar herniation. There may be some associated features with headache like eye pain or reduced vision. This occurs in case of acute glaucoma. It happens typically in elderly people, long-sighted people. Constant pain rapidly develops around one eye, radiating to forehead, and markedly reduced vision. There may be visual halos, and the eyes may be congested. Uh, so immediately seek expert help. If delay in treatment more than 1 hour is likely, give eye drops like 0.5% timolol maleate, that is a beta blocker, and 2% pilocarpine, and acetazolamide 50 milligram per hour. In acute glaucoma, there will be acute onset headache around the eyes. There may be reduced visions. There may be visual halos. So treatment should not be delayed for more than 1 hour. We should start timolol, pilocarpine eye drops, and acetazolamide 50 milligram per 500 milligram per hour. Jaw claudication, tender scalp with thickened pulseless temporal arteries. This is by vasculitis. This is giant cell arteritis. We also call it temporal, superficial temporal artery is involved here. This is subacute onset. ESR will be raised here because this is vasculitis. ESR will be raised. It should be excluded in all people more than 50 years with a headache that lasted few weeks, and steroids should be started promptly. Never do a biopsy of superficial temporal artery. The treatment is steroid here. Okay, let's come to the character of headache. If the headache is tight, bent, or dull pressure sensation, it is usually tension type headache. It is usually bilateral, non-pulsatile headache, and there may or may not be scalp tenderness. If the headache is throbbing, pulsatile, and lateralizing, then it is migraine. Next, come to frequency. Continuous headache, it may be chronic migraine, it may be medication overuse headache, it may be hemicrania continua. This is a rare condition in which unilateral features are found, and it responds to endomethacin. Sinusitis is also a chronic headache. There may be tenderness over frontal or maxillary sinus or tenderness, and there may or may not be postnasal drip. So if the headache is continuous, we should consider chronic migraine, medication overuse headache, hemicrania continua, and sinusitis. Headache that is pain-free in most days. It can be migraine, it can be in trigeminal neuralgia, trigeminal autonomic cephalgias, that is also cluster headache. We should also take drug history in headache because this is important in medication overuse headache. What are the culprits here? Culprits are mixed analgesics like paracetamol plus codeine or opioids that are found over the counter, ergotamine and triptans more than 3 days per week. This is a common cause of a chronic daily headache. Analgesics must be withdrawn, and aspirin and naproxen may mollify the rebound headache. This is what to mention. Aspirin and naproxen may mollify the rebound headache. What happens in most cases that people go to the pharmacy and ask for some medication for headaches, and people give them paracetamol and codeine combinations. Uh, okay, a preventive may help once of other day, like tricyclic antidepressant and valproate or gabapentin. Limit use of over-the-counter analgesics. Not more than 6 days per month. That is the message to take. Limit use of over-the-counter analgesics not more than 6 days per month. Social history. Ask about stress, recent life events, any stressful, traumatic life events or not. May not explain the pathology, but will for sure help you appreciate the context in which symptoms are experienced. In post-traumatic stress disorder, there may also be headache. So this is the basic discussion regarding headache. So now let's move to some specific types of headache that are of real importance. Like let's start with first trigeminal neuralgia (TN). Symptoms. Symptoms are paroxysms of intense stabbing pain lasting seconds in the trigeminal nerve distribution. We know the trigeminal nerve distribution, facial, mandibular, and maxillary division, typically affecting maxillary and mandibular divisions. Uh, Face screws up with pain, hence tic dolorax. It's also known as tic dolorax. What are the triggers? It may start with washing the affected areas like eating, shaving, talking, or dental prosthesis. We know that most often in our clinical practice, we find that TN triggers after dental work. Secondary causes compression of trigeminal root by anomalous aneurysmal intracranial vessels, a tumor or a chronic meningeal inflammation, multiple sclerosis, herpes zoster, or Arnold-Chiari malformation. So these are the secondary triggers. We should do an MRI in that case to exclude the secondary causes. Treatment treatment usually involves carbamazepine 100 milligram 12 hourly, then tapered to 200 to 400 milligram per 24 hour per hourly, or we can use gabapentin. Tricyclic antidepressants are commonly used in Bangladesh, but the real drug is carbamazepine. But because of the side effect of rash and the fear of Steven-Johnson syndrome, people switch to tricyclic antidepressant and gabapentin. Even pregabalin can be used. Surgery may be necessary if refractory to drug treatment. This may be directed at peripheral nerve, trigeminal ganglion, or the nerve root. It's all about surgical decompression. We know the secondary causes like compression of the trigeminal root by an anomalous aneurysmal intracranial vessels or a tumor. So in that case, decompression is the surgical treatment. Microvascular decompression. We talked about this. Anomalous vessels are separated from the trigeminal root. And stereotactic gamma knife surgery can work, but length of pain relief and the time to treatment response are limiting factors. So this is all about trigeminal neuralgia. So now let's move to migraine. Migraine, it's a very common condition and it's a very popular condition. Before moving into migraine, we should look what's going on migraine, what's happened on migraine. I always say that people who understand neuroanatomy better will always understand neurology and psychiatry better. Because this is the basic. Without knowing neuroanatomy, understanding neurology and psychiatry is very difficult. Underlying pathophysiology of migraine is very poorly understood. The MRI, frequent MRI was done during acute attacks of patients, uh, and it showed episodic cerebral edema, dilatation of intracerebral vessels, and reduced water diffusion, not respecting vascular territories. So the priority event may be neurologic. So the primary event may be neurological. It's very non-specific. During acute attacks, frequent MRIs were done, and it shows that episodic cerebral edema due to dilatation of intracerebral vessels. Very non-specific, does not relate to the actual cause of migraine. Uh, Positron emission CT scans was done during migraine attacks, and it showed that migraine is a subcortical disorder affecting modulation of sensory processing. That also does not satisfy our thirst regarding the pathophysiology. Magnetoencephalographic studies (MEG) have shown resting excitability in at least the visual cortex, suggesting a failure of inhibitory control. That is also non-specific. Hormones also play a role. Elevated levels of serotonin metabolites in the urine during migraine attacks was found. So these were all about what was found regarding the pathophysiology of migraine, but the consensus is it's still poorly understood. So let's proceed to migraine clinically. Symptoms, there may be a prodrome. Premonitory symptoms for hours or days before headache are present in majority with migraine. There may be tiredness, yawning, mood or concentration change. Mood or concentration change. This is very common. Aura. Aura, this is a reversible neurological symptoms are present in one-third of cases, usually gradual onset and resolves typically within an hour, usually preceding the headache but may also accompany it. Aura can be visual, like chaotic, distorting, melting, jumbling of lines, dots. So these are visual halos, scotoma, hemianopia. These are the visual aura. And there may be somatosensory aura, like paresthesia, spreading from fingers to face. There can be motor auras, dysarthria and ataxia, migraine. If the migraine is arising from brainstem area, there may be ophthalmoplegia, hemiparesis. Hemiparesis may be misdiagnosed as transient ischemic attack or stroke. So migraine is such a peculiar disease, and its pathophysiology is so poorly understood that it may even mimic transient ischemic attack or stroke. Speech. 8% of auras arising from temporal lobe. So these are auras, or these auras are malfunction or hyperexcitability or hypoexcitability of different regions of brain, like frontal, temporal, brainstem. So what are the typical features of migraine headache? It will be unilateral, not bilateral like tension type headache. It will be throbbing headache, typically aggravated by head movement or physical activity. Median duration is 24 hours. Median duration is 24 hours. Accompanying neck pain, vomiting, and photophobia. There may be allodynia. Allodynia means all stimuli produces pain. And there may be nausea also. There may be vomiting also. So these are the typical features of migraine headache. So postdrome. There is also not only prodrome, there is also a postdrome. Postdrome occurs in 80%. Symptoms similar to those listed in prodrome, usually lasting less than 12 hours. There are some triggers of migraine. We should know that these triggers are seen in 50% of cases. Most commonly, chocolates. People who are fond of chocolates with migraine, should avoid chocolates. Chocolates, hangover, orgasms, cheese, coffees, alcohol, travel, or exercise. Diagnosis is always clinical, based on history. Uh, what is the diagnostic criteria? Let's go to this. It's very important. Diagnostic criteria of migraine. We cannot diagnose migraine out of no basis. Diagnostic criteria is if no aura greater than 5 headaches lasting 4 to 72 hours, plus nausea or vomiting, or photophobia or phonophobia, plus any two of pulsating, unilateral worsened by routine activity. So diagnostic criteria: if no aura, more than 5 headache lasting 4 to 72 hours, plus nausea or vomiting, or photophobia or phonophobia, plus any of pulsating, unilateral, or worsening routine activity. So, what are the differential diagnosis of migraine? It may be cluster headache, basic tension type headache, cervical spondylosis, raised BP. People with hypertension often complain of neck pain. Intracranial pathology, sinusitis, or otitis media, dental caries. Dental caries triggers TN and that mimics with migraine. And TIS may mimic migraine. So how we are going to manage migraine? Acute management. Triptans in combination with NSAID. This is the acute management of migraine. Triptans in combination with NSAIDs, preferably paracetamol in mild to moderate attacks. Use triptan cautiously. Use triptan cautiously if there is prior history of cerebrovascular event. Triptans are contraindicated in ischemic heart disease and coronary spasm, raised BP, and if the people is using lithium or SSRI. So, patient with a migraine and also depression taking SSRI, taking SSRI cannot be given triptans. Rescue IV therapy may be beneficial if acute and emergency presentations like IV metoclopramide. Some non-pharmacological therapies like warm or cold packs to head, uh, and acupuncture. Uh, NICE recommends acupuncture, at least 10 sessions of acupuncture over 5 to 8 weeks if both topiramate and propranolol are considered are unsuitable or ineffective. Uh, Transcutaneous electrical nerve stimulation (TENS). This is a form of acupuncture. This also helps. So, prophylactic treatment, reducing frequency of migraine attacks is important. Uh, Prophylactic treatment can achieve a decrease in more than 50% of acute attacks frequency in most patients. First line treatment is propranolol 40 to 120 milligram 12 hourly, or topiramate 25 to 50 milligram 12 hourly. Topiramate is recently very popular. but it's teratogenic uh, and can interfere with the oral contraceptive pill efficacy. Patients may be previously on prophylactic medications like valproate, pizotifen. Pizotifen was very popular previously, pregabalin or ACE inhibitor. If achieving good control, continue accordingly. If the previous drugs are achieving good control, we don't need to change them. We can continue them. 12-weekly botulinum toxin type A are a last resort if in chronic migraine if other prophylactic drugs are ineffective. Tricyclic antidepressant like amitriptyline 10 to 75 milligram can be considered also. Consideration in females. Incidence of migraine plus aura and ischemic stroke are increased with OCP use. This is very important. If the patient is using OCP, incidence of migraine and aura and ischemic stroke risk is increased. So in that case, progesterone only pill is therefore recommended. Progesterone only pill is therefore recommended, and we should advise for reducing smoking, weight loss, strict control of diabetes, controlling hypertension, controlling dyslipidemia, etc. Premenstrual migraine. Premenstrual migraine is a special form of migraine. If it is uncontrolled with standard treatment or onset of headache is predictable, then consider frovatriptan. Frovatriptan 2.5 milligram BD or zolmitriptan 2.5 milligram BD on the days migraine is expected. So let's point out this. In premenstrual migraine, if it can be predictable that when headache is going to happen, frovatriptan or zolmitriptan 2.5 milligram BD on the days of migraine is expected. So now let's proceed to pregnancy. This is very important. And it's also very complex. Managing migraine or managing prophylaxis treatment in migraine. Usually, due to the physiology of pregnancy, migraine improves. How? We don't know. If not, worsening headaches in pregnancy are associated with a greater risk of preeclampsia and cardiovascular complications. Migraine in pregnancy are associated with a greater risk of preeclampsia and cardiovascular complications. In acute attacks, paracetamol are the first line choice. Triptans and NSAIDs can be used, but discuss risk and benefits with patients. It is better to collaborate with a obstetrician. Avoid aspirin if breastfeeding. But in pregnancy, during the first trimester, some obstetrician prescribe aspirin. Antiemetics like cyclogen and promethazine for morning headache can be used, but there is still debate regarding which prophylaxis we are going to use. We cannot use topiramate, we cannot use propranolol, we cannot use pizotifen, we cannot use tricyclic antidepressants. So, how to reduce frequency of acute attacks in pregnancy still remains a debate. So this was all about migraine. Now let's come to the last one. This is cluster headache and other trigeminal cephalgias. Trigeminal cephalgias are a group of primary headache disorders that involve activation of trigeminal and parasympathetic systems, characterized by short-lasting unilateral pain with variable ipsilateral cranial autonomic features. Etiology is unknown. So cluster headache is common among them. It is the most common, probably the most disabling primary headache disorder. It is probably the most disabling primary headache disorder. Onset can happen at any age, commoner in smokers. Symptoms: rapid onset, excruciating pain around one eye that may become watery and bloodshot with lid swelling, lacrimation, facial flushing, rhinorrhea, meiosis, and even ptosis also. Pain is strictly unilateral and almost always affects the same side. Agitation is typical during attacks in contrast with migraine. It lasts 15 to 180 minutes. That means it lasts about 15 to 3 hours, occurs once or twice a day, and is often nocturnal. Clusters last 4 to 12 weeks and followed by pain-free periods for months or years. Treatment during acute attack: keep calm, carry oxygen. Give 100% oxygen for 15 minutes via a non-rebreathable mask. Not if the patient is a case of COPD. So, the treatment of acute attack of cluster headache is 100% oxygen for 15 minutes via a non-rebreathable mask. But remember, if the patient is a case of COPD, do not give them. Sumatriptan subcutaneously 6 milligram at onset, or zolmitriptan nasal spray 5 milligram can also be used. We can prevent this by avoiding triggers like alcohol, medications like verapamil. You can use medications to prevent acute attacks like verapamil 300 milligram TDS is the first line. Also consider corticosteroids, short term only. We can also consider topiramate and lithium. Paroxysmal hemicrania. These are shorter duration, 2 to 30 minutes, but more frequent attacks than cluster headache, up to 40 per day. This responds to indomethacin. This is a rare condition. So now let's come to the last one, SUMET, short-lasting unilateral neuralgiform headache with conjunctival injection and tearing. This is called SUMET. This is shortest duration of headache, lasts only seconds to minutes, but highest frequency up to 100 per day. So a patient continuously complaining of headache, we can consider SUMET. So I think this will be okay for basic understanding of headache and general practice or specialties.